So I'm Amber. I'm a fellow here at San Diego Spine, and today we're going to talk a little bit about biomechanics. We'll start with a little bit of relevant biology, and then we'll talk a little bit about metallurgy, and finish out with some of the principles of instrumentation. So a little bit about the biology. It's important to understand Wolff's law with respect to the biomechanics of spine. The principle of Wolff's law is that bone reacts to applied loads. And so you can kind of see this basic diagram on the right. There is a sensory perception of the applied load to the bone itself. This results in a cell activation and a growth response. And so this is in one of the original papers on the left, Virchow's paper, which discusses the response of bone to externally applied forces. And you can see that the calcar of the femur is the thickest and most robust portion of the femoral bone. And that is as a response to the shear forces that it receives on a daily basis. So it's important to understand of Wolff's law and how it relates to the biology of bone. Now, how does that work on a cellular level? This is all mediated by osteoclasts. So these are connected by canaliculi and are strain amplifiers. And the way they kind of talk to each other is known through a mediator known as sclerostin. And sclerostin for us is not something that we want to see as far as high loads of it, because it's produced by the osteoclasts as a response to low mechanical loads, such as immobilization or paralysis or just overall decreased activity. And so what happens is that sclerostin actually blocks the Wnt beta-catenin pathway. So the way to think about this is just with respect to the rank ligand pathway. So as rank ligand activates osteoclasts, so does the Wnt beta-catenin pathway for osteoblasts. And so unloaded osteocytes will secrete sclerostin, which decreases the bone mass. So it blocks osteoblasts, their formation, their function, and can even play a role in apoptosis. And so the link between Wolff's law and sclerostin is that when we don't have applied loads, we have increased amounts of sclerostin produced, which is bad for the osteoblasts. And so mechanical loading is a good thing. It inhibits the sclerostin production and ultimately improves the bone mass. And this was a study that looked at cyclical compression stimulating osteoblast formation, and that's through the activation of this Wnt and beta-catenin pathway. And so the important part is the pathway down to the left. They did cyclical loading and looked at the expression and formation of osteoblasts. And you can see that there's kind of a sweet spot when they perform cyclical compression at a certain rate after 6 hours that improved the expression and formation of the osteoblasts the most out of all. So there is definitely an important component to applying loads to bone. And so it's a little bit of a biological recipe when you think about it, especially from an orthopedic standpoint. When you want to form osteoblasts, you need high loads and high oxygen content, and that will activate the Wnt pathway. If you, in the same respect, get high loads, but low oxygen content, you will actually activate the SOX pathway, and the SOX pathway actually forms chondroblasts. And the reason this is important is because it relates to the construct stiffness, and when we're talking about forming our different forms of constructs. So it's a little bit of like a Goldilocks complex. If you have too much motion, too much load on the bone, you actually will get cartilage formation and pseudoarthrosis. If your construct's not stiff enough, this is what can happen to your fusion mass. Now, if your construct is too stiff, you can get no bone stimulation and just kind of a lack of osteoblast formation, but no real chondral formation. And so you can actually see this with different types of pseudoarthrosis. So it kind of relates to the amount of stiffness that you see in your construct. And so you kind of want to try to optimize the biology and the biomechanical construct stiffness. So a little bit more about the biomechanics. So basic concepts of stress. We all know about stress. This is the force per unit area. There are different types of stresses or forces. So there are tensile forces, compressive forces, and shear forces. And we'll talk a little bit about how each of those relate to bone here in a little bit. And then there's the concept of strain. So strain is basically a unitless concept, and it's a change in the length of an object compared to its original length. So it's this ratio when a force is acted upon an object that is equivalent to strain. And this is important because we then form these stress strain curves. So you know, in all of our residencies, we've looked at these, and for boards too many times, but the stress is on the y-axis, the strain is on the x-axis, and you have this elastic region, and the elastic region is basically once a force is applied to a load, if the object returns to its normal shape and construct, it will be, it is considered to be elastic. So if you stretch a rubber band and it returns back to normal, then that would be the elastic region. Once it reaches a point called the yield point where it no longer returns to its normal shape or shape, that is then the plastic region. So you've now had deformation. So if you're bending a rod, if it reaches its yield point, it then becomes plastically deformed and it doesn't return to its original shape. And so that's the way to kind of think about it. And then the other important part is the fracture point. So that's at which point it has deformed so much that you would then actually fracture the rod. So you were hulking out in the OR and you bent the rod until it completely fractured. And so that's the way to kind of think about that. And this is important because it relates to Young's modulus, which is basically the rise over the run of that stress strain curve. And different materials that we use have different Young's modulus. So here's the Young's elastic modulus of different materials that are commonly used in orthopedics. And then I think the important part of this is to note that all of the metals that we use are have an extremely high Young's modulus when you compare it to cortical bone. And the one that is the most closely related is titanium, but it's still almost 100 times the Young's elastic modulus of cortical bone. So it's important to keep that in mind. This is the different Young's modulus for the different types of metals that we use in surgery. So if you look at 5, this is the Young's modulus of cortical bone. 4 is that of titanium, which we know is the most closely related to titanium. Titanium is most closely related to bone, sorry. Stainless steel is next. Cobalt chromium is second, and then ceramics are actually have the highest Young's modulus. However, they're brittle materials. And so the concept of a brittle material is that the yield point and the breaking point are very closely related. So brittle materials don't have a lot of plastic deformation, which makes sense. You know, if you use ceramics, you're not really able to deform them much before they break. Whereas other materials have an extremely large plastic zone before they reach their breaking point, and those are known as ductile materials. The other concept to understand is anisotropic versus isotropic materials. So this is basically that different materials will have different material properties based on the direction that the force acts on them. And bone is a classic example of an anisotropic material. So if you look at it, it acts different ways and has better stress. It has different Young's modulus when you compare it to different forces acting on it. So it works best in compression, which makes sense. Axial compression forces tend to have the bone act in its best response to this. You can see the stress strain curve over to the left. And tension is kind of the next acting force on it, and then bone tends to react very poorly to shear. And you can actually see this when we look at different types of fractures. It's much more difficult to create a fracture with a compressive force when you compare it then to shear forces or torsional forces. So there's a lot of different types of metals that we use in spinal devices. These are some of the most common. So stainless steel, titanium alloys, cobalt chromium, and nickel titanium or nitinol. And they all have different pluses and minuses to them. So we'll start with stainless steel. That used to be used more commonly, but has kind of fallen more out of favor, and I'll kind of talk about why. So it's very strong and very stiff. We looked at its Young's modulus before. It's very inexpensive. However, it does have a couple of disadvantages to it. So number one, it contains nickel. So it's not something that you would want to use in patients who have nickel allergies. And it also is very susceptible to corrosion and has poor biocompatibility. So galvanic corrosion is something that we have to think about when we think about mixing metals, especially in spine, when you talk about connecting screws to rods. And basically the idea of galvanic corrosion is you use two dissimilar metals, and this forms a battery. So there is an electrode and a cathode, and you get a current flow, and this causes galvanic corrosion between the two metals. So this is an example paper where they looked at spinal metallosis in patients, and what you can see is that these rods, these are highly focused pictures of the rods after they were retrieved from the patient. And you could see that the junctions between the connectors, i.e. the screws and the rod, were highly corroded. And this was seen in patients who had stainless steel rods used in their constructs. And so this can lead to rod fracture and construct failure. On the left, you can see the different kind of nobilities of the different metals, and you can see that titanium is very low on the spectrum, so it tends to be more resistant to galvanic corrosion, whereas stainless steel is fairly high and is much more susceptible to it. And the reason that titanium is more resistant to this corrosion is because it's very good at forming a passivation layer. So metals obviously can corrode, and they can corrode in vivo when they're exposed to oxygen. And so metal implants that perform a protective oxide layer tend to corrode less in vivo. And so titanium is really good at this. It's highly biocompatible and forms a good passivation layer, whereas stainless steel is very poor at forming this passivation layer. And so it's more susceptible to galvanic corrosion and the formation of those and transfer of electrons and the formation of the battery. So titanium is good, but it does have some negatives to it as well. So the advantages are it's lightweight, strong, and flexible. It's a little bit easier to bend, and that's relative to its Young's modulus. So it's easier to kind of bend into your constructs. It's relatively expensive, however, and it is not sensitive. And so I'll kind of show you a little bit more about the notch sensitivity of the rod. So this was one of the original articles that looked at the notch sensitivity of titanium alloys, and they basically compared different metals, including stainless steel, titanium alloys, commercially pure titanium, and they used different types of rod bending techniques or placement of connectors that could potentially form notches in the rod. And then they looked at the fatigue life of the different rods and looked at which ones fared the best. So up on the top, you can see the stainless steel rod preparation had no notch formation. That's the rod at the very top. And then the two below that are titanium rods, one made with a French bender and one after a connector was placed. And so they prepared these metals in these 4 different ways as described below. And then they exposed the rods to a 4-point bending cycle up to 100 million cycles, and then looked at their fatigue life. And this is the graph that you can see here from load to failure. So SS is the stainless steel, the gray is the titanium alloy, and then the commercially pure titanium is kind of the dots. And the titanium alloys and the commercially pure titanium are very sensitive to notch formation. And so when you use French benders or connecting bolts, that can create notches in the titanium. And this will ultimately decrease the fatigue life of the rods. So in the paper, they kind of caution about when you are bending, you know, if you're doing repetitive rod bending for a titanium rod in order to get it to fit, you may want to consider exchanging that rod if you've been overbent it too much, because you've significantly decreased the fatigue life of the rod itself. So what about cobalt chromium? It's very stiff. It has a very high Young's modulus, and I think anybody who's tried to bend cobalt chrome rods knows this. It has a good self-passivation, so it's very similar to titanium in forming that protective oxide layer and preventing galvanic corrosion. It's expensive, so that's something to keep in mind. And then it also has a very high fatigue strength. So this is the comparison again of those different types of Young's modulus for the different metals. So titanium as the closest to being to bone, and then cobalt chromium with the highest Young's modulus. And then these are the different yield strengths of the metals. So stainless steel actually has the lowest yield point. Titanium is better than stainless steel, and then cobalt chromium is at the top. It's also important to consider this fatigue life, especially with how it kind of relates to the notch sensitivity in titanium. So the way to think about fatigue life is it's the endurance limit of the metal. So how long does it take to fail when it's exposed to multiple cycles? And the reason it's important is because of the example down here at the bottom, where the rod fatigues and breaks, and then you have failure of your construct. So this was the comparison from a different paper that showed the fatigue life of titanium. And again, this is when it was exposed to different types of fridge benders or connectors. Again, so that's showing its notch sensitivity, while steel doesn't have that. Stainless steel doesn't have that kind of sensitivity, and neither does cobalt chrome. So we know that stiffness is important with regards to optimizing biology. And so what factors play into the stiffness of your construct? So the stiffness of the rods is mainly subjected to cantilever bending. And so it's important to just keep this equation in mind, because this is the way that you can change these different parameters to increase the stiffness of your construct. So the first is by choosing the rod type. So this has to do with the Young's modulus of the different components that you might choose, or rod types that you might choose. So the example of using a titanium rod versus a cobalt chromium rod. The diameter of the rod also plays a very important role, and you can see that it is to the 4th power. So the diameter of the rod is a very powerful component when you're trying to attempt to change the stiffness of your construct. And then the last is by decreasing this L component of the equation. And this is has to do, when you look at spines specifically, the increased frequency of placing your different screws. So the more frequent you place the screws, the smaller the L in between the screws and the more stiff the construct. So if you were attempting to make your construct more stiff, you would increase the frequency of your screws. If you were trying to look to make your construct maybe less stiff, perhaps at the top of a construct, and provide a more transition zone, you would actually decrease the frequency of your screw placement. So here is the relative stiffness among the available rods and with respect to the rod sizes. So cobalt, chromium, 6L rods are the stiffest rod that you can choose. You can see titanium here being less stiff on the spectrum, and then even a titanium 6L rod is still less stiff than a cobalt chromium 5.5 rod. So that's just something to kind of keep in mind. And then this is an example where they used a pedicle screw at the level of a burst fracture, trying to increase their stiffness of their construct, and then they compared the two sides, and the stiffness of the construct increased by 60% when they used the screw on the side that had an available pedicle versus the side that the pedicle unfortunately was unavailable for implant placement. And so that just kind of is an example that shows how you can adjust stiffness of the construct just by the placement of screw density. So the last thing I want to talk about is a little bit about the biomechanics of different the pedicle screws. So this is a really great paper that kind of discusses all of the basics, and I'll actually probably send it to Cameron. It's really good. But it talks about 3 basic parameters of pedicle screw instrumentation that are the most important to your understanding. So the first is that the outer diameter, which is the large D over here, is the most important with regards to pull-out strength. The inner diameter has to do with the fatigue strength of the screw itself. When you're looking at screws, the dorsal cortex of the spine should not be violated, and so we'll talk about pedicle screw violation within the cortex and why that's important in its regards to length. And then what can you do for these pedicle screws in order to augment them in cases of osteoporosis or revision. So pull-out strength of a screw is related to this equation here. And the basic idea of this is that the amount of bone that's in between the threads here, the pitch is the space between the threads, and the amount of bone that's formed in between these threads is the most important component of the pull-out strength of the screw. So anything that will optimize that amount of bone is something that is going to improve the pull-out strength of the screw. So smaller inner diameters, larger outer diameters of threads, shorter pitches, and then the actual quality of the bone help to increase the pull-out strength. So this is a study that looked at the structural integrity of the pedicle and its role in stability. And basically they divided the pedicle up into different zones, and then they calculated the bone mineral density based on these circumferential layers, and then compared it to the body and evaluated the screw stability in these different regions. So the importance of this graph shows that the largest bone mineral density is obviously within the pedicle, and this is most related to the pull-out strength of the screw, specifically how much purchase the screw gains within the pedicle. And then you can see the difference between individuals who had osteoporosis and normal bone. And the basic idea is that the body doesn't add a significant amount of pull-out strength to your screw. It is mostly the pedicle itself. And you can see the pull-out force and then the caudotocephalad stiffness of the screws. And really the pedicle was the thing that provided the most pull-out strength and the most stiffness to the construct. So, and they kind of note that here. The other thing that is important is that when you are placing it into osteoporotic bone, the osteoporotic bone, the cortical thickness is decreased, and so you have a higher potential for blowing the screw out of the pedicle. And so it's not always as optimal to completely fill the pedicle because you have a higher risk of blowing out the cortical wall because it's so thin. And that was the other important part of that study. And then this is the fatigue life of the screws. So again, we talked about the inner diameter. This is a study that looked at the inner diameters of screws and how they contribute to the fatigue length or fatigue life of the screw. Fatigue strength increased 104% just following a 27% increase in the inner diameter of the screw. This is a study that looked at this, the TSF is that amount of bone that is within the threads between the inner diameter and the outer diameter of the screw, and looked at how the screws reacted to different material densities. And so the increasing thread depth, which we kind of talked about, decreasing the thread pitch, increases the screw purchase in different porous materials. So those are some things that can be done in poor quality of bone. The study also looked at the effect of tapping. So it is important to know that tapping can reduce the pull-out strength of your screw. In this study, it reduced it by 8%, and this was because it was associated with a 20% reduction in the bone volume. And so the thought is, well, why do you tap? And that is because the tapping can improve the trajectory. It's also really important in really tough bone because you can actually blow out the pedicle screw due to increasing hoop forces of the pedicle. So tapping does have its place, but it's something that you should think about maybe in poorer bone to maybe not tap. Just because you're reducing that bone volume so significantly. This study showed that tapping improves the trajectory and that there were higher cortical breaches of the pedicle when the screws were not tapped. And so generally the recommendations are that under tapping by 1 millimeter through biomechanical studies has been shown to be safe and conserve the pull-out strength of the screw hole, but if you tap to the same size, it significantly will reduce the purchase of the screw and increase potential screw pullout. Screw trajectory is also important, so convergence of your pedicle screws by 30 degrees in the coronal plane can increase the pullout strength by 28.6%, and this was the study that kind of looked and demonstrated that. And then screw length is important as well. So again, we said that the screw main pullout strength comes from the pedicle. And so these studies looked at, well, how far into the body should you go, what's safe, and where do your returns kind of minimize versus your risks of breaching anteriorly. And they basically show that about 80% penetration is 70 to 80% is the max. You don't really get much more out of the body in terms of biomechanical pullout. Versus just kind of tapping or placing the screw, unless you obviously go bicortically, but within the vertebral body itself. And finally, just a little bit about cortical screws. So these are different types of pedicles. These are not pedicle screws. They are cortical threaded screws. They're short. You start medial and you go lateral rather than the lateral to medial trajectory of the pedicle screws. And they tend to have smaller diameters, but they, in biomechanical studies, have been shown to have really good load to failure. This is a study that came out of the Spine Journal in 2014, where they showed higher load to failure in cortical screws when comparing them to pedicle screws, as well as pull-out resistance. So it is a good option. Also, if you are unable to get a pedicle screw, it's a good bailout screw. And then briefly, real quick about cement augmentation. This study kind of looked at, was a meta-analysis of a bunch of different types of different cement augmentation studies. They showed anywhere from 50 to 250% pull-out strength. And the reason this varied was it matters the bone quality. So even though we do it in osteoporotic bone, if you do cementation and augmentation in bone that is of poor quality, it actually has less augmentation than in good bone, which is kind of unfortunate. And then these two studies looked at, well, how much is the optimal amount of bone cement to place? And what they found was that it depends on where you are in the body. So 1 millimeter enhances is found to be kind of the optimal cement augmentation for a thoracic body. And then comparing that to the lumbar regions, you really need about 3 cc's of cement augmentation to enhance the pedicle screw by about 75%. So, and then this was talking about the timing. Ultimately, the idea is that placing the screw at the time the cement is, before the cement hardens, is the optimal timing. Now, I know we have fenestrated screws now, so this doesn't matter as much, but when they were first looking at it, they placed the cement first and then placed the screw. If you waited too long, the augmentation of the cement was lost, and also had less kind of diffusion within the trabecular bone. And then a real quick thing about crosslinks. So basically the idea of a crosslink is to prevent this thing called racking, which is where you form a parallelogram and it kind of collapses on itself. Studies have really looked at these and shown really axial rotational stability is provided by transverse connectors. This study actually looked at, where should you place them? What's the optimal placement? This one, it suggested one in the middle and one at the proximal 1/8 of the longitudinal rods if you're optimizing it biomechanically. But they really only suggested it in certain cases. So if you had anterior column instability, or you're correcting a rotational deformity, because they really don't have a lot of biomechanical function when it comes to like flexion and extension stability, anything like that. It's mostly for rotational stability. And they do come with certain complications. There's rod notching and fracture, which we talked about earlier. It can interfere with the placement of your bone graft. And there are case reports of them causing dural erosion. So that's something to keep in mind as well. So I know that was a broad topic, and I tried to kind of hit on the highlights. But hopefully that was somewhat useful to people.
Great job, Amber.
Yeah, great job, Amber. Yeah, it's a tough topic. Nice job.
Really important for you to have a good handle on as you go out and you have to make these choices. So your choices of what you use in the operating room are informed by some foundation. And I know we get some of it in orthopedic basic science, but there's some specifics to spine that are important to take away from this sort of talk and topic in general. Any other input from the faculty?
No, Bob, I think that's great. I think the understanding of the basics as you make your decisions, thoughtfulness about stiffness, thoughtfulness about material you're going to choose, what your goal is, what the long-term issues are going to be. I just think that all this is really good idea of screw pull out, where your failure points are, just based on the biomechanics of what we're doing. Amber, that was a really good talk on this.
Thank you.
Yeah, great job, Amber.